Okay, so good morning, good afternoon, and good evening to you all. Welcome to our last of the year ASPI meeting. We decided to try something a little different, a little more casual for our last meeting. We have no meeting in December. We're dark, and so we're going to have more of an open forum this time and let people, as the title says, ask the board anything. Can't say we'll have an answer, but you can always ask. So, the one thing that I do need to get out of the way, as far as our administrative duties, and that is our disclaimer. So, I'd just like to read that very quickly. The information and opinions expressed in this presentation, both verbal and written, are not intended as recommendations by ASPI or its representatives for any medical treatment, product, or course of action. You should always consult a doctor about your specific situation before pursuing any health program or treatment. So, with that out of the way, again, this will be an open forum. Just ask everybody to be polite, not hog the show. Feel free to ask your questions. And with that, I will turn the meeting over to Chairman and fearless leader, Mark Lichty.
Thank you, Bill. And thank you all for attending this morning. I want to, with the board, we have a lot of years here of active surveillance experience. I've got 18 years. I think Bill has about 14 years. And Howard, who is a founder and really were very much involved with us, too has many years of active surveillance experience. Unfortunately, a couple of us won't be in attendance today. Martin, one of our board members, has COVID, but still, we have a lot of resources here. And I had asked the board if they could share with you what the most difficult part of their active surveillance journey was. Maybe there's something to learn from that. Soon after that, you're going to just turn it over to you and you can ask whatever questions you want. But I thought that might be helpful background. So if I could, I'll start off just to give a tone to what I'm speaking of. So it was 18 years ago that I was diagnosed and I went on active surveillance. I'd mentioned just a couple minutes ago that at that time I read the China study. I went on a vegetarian diet, and actually 4 years ago I had a micro ultrasound and they couldn't even find the prostate cancer. So at this point, I don't even know if I have prostate cancer, but I suspect I do. But the most difficult part of the journey for me was that there were 5 medical professionals that recommended a radical prostatectomy at that time. And I only knew one other person that went on active surveillance. And the hardest one of those 5 people, the professionals that recommended active surveillance, that recommended a radical prostatectomy, was my wife. She was a nurse practitioner. She was a medical professional. And she wanted me to get a radical prostatectomy. And
Mark, I always wondered if she just was giving you the cold shoulder there.
Well, I don't know. I don't know that, but anyway, I recall saying to her, sitting on the couch and saying, "Wendy, that's not the kind of support I need," with even more emphatically than that, because I needed to hear the words. I know, honey, this is going to be a hard journey, but I'm here with you. That's not what I heard. And 4 or 5 years later, she came back to me and said, "Mark, you were right." But it took a while for her to get there. So that was the hardest part of my journey. Howard, do you want to go next? What was the hardest part of your journey?
Well, I'm coming up to an anniversary in early December. I like to call it my praz mitzvah. It's going to be 13 years ago in December that I was diagnosed. And for the most of these 13 years, it's been pretty easy as far as I'm concerned. But the hardest time, I think, was on a Friday evening. I get called by this doctor who scared the shit out of me. He said, I have bad news for you. You have prostate cancer. He didn't say low risk prostate cancer. He just said prostate cancer. Can you see me in my office next Tuesday? And I had already done a lot of homework on this, so I was kind of prepared, but I wasn't prepared for what he told me. He gave me a hard sell on having surgery. I already knew about active surveillance, and I already had lined up a second opinion at the University of Chicago. The doctor I saw, it was a community doctor out in the suburbs here, who trained at the University of Chicago under the grandfather of active surveillance, Jerry Chodak. But this guy, I think, was out to make a buck. And, he just kind of, I said, do you support active surveillance? He said, I don't support that modality. So he more or less pushed me out of the nest. But I would say that was the hardest time for me, and I would say also a few months before that, I lived with a lot of uncertainty for about 6 months because I think my family doctor kind of pulled the alarm prematurely. My PSA had gone up to like 3.6 or something like that, and he was shuttling me off to see a urologist immediately. And I'd never had anything seriously wrong with myself up to that point. So I kind of figured I'd come out of it unscathed. And so I got my first diagnosis, or my first Gleason reading was ambivalent. I got a second opinion from Dr. Epstein 13 years ago. And he said, come back in 6 months and do it again. The only thing they found was a high-grade pin, which in those days they saw as a precursor to more serious cancer. They don't anymore. So, for about 6 months, I lived with a cloud over my head too. And then it culminated with this doctor trying to talk me into surgery. And then I saw a second doctor who said, you're the poster child for active surveillance. 13 or 10 years from now, I predict, your prostate cancer will not have even grown. Well, he was right, and it was even better because it wasn't even seen. And through 4 more biopsies, it never was seen again. So, at any rate, that's my sad story.
Bill, you want to go next?
Sure. As Mark said, it's been 14 years for me since I was originally diagnosed. And at the time, of course, active surveillance more or less didn't exist. It was really watchful waiting, which basically meant you just waited and watched for something to get really bad and then try to treat it at that point. Active surveillance being active, of course. But to get to the point of the hardest part of that was in the initial stages, which both Mark and Howard have described for themselves, which is the uncertainty of what exactly is going on. For me, it was more of a problem to be solved. For my wife, on the other hand, this was are you crazy? You've been diagnosed with cancer. There's no such thing as not having treatment. And of course, there are those horror stories that we've heard of celebrities and others who have had, serious advanced cancer and, gone the peach pit route and of course end up dying. And so that blanket gets thrown over everybody that gets diagnosed with cancer. So in the beginning, trying to buy myself some time to research and learn more about it, which she was in support of, but still kind of like, well, it really seems like you need a treatment. And after we saw the surgeon, the radiologist, and it just really didn't feel right. And reading the China study and then getting a color Doppler ultrasound at that time, which I've now graduated to MP-MRIs, that was really the turning point. And I convinced her that with some lifestyle changes, dietary, more exercise, and keeping an eye on this, that I should be okay. And at least right this moment, at that moment, I didn't need to do anything. So that convinced her that, okay, I'll give you some time. And after about a year and learning more about active surveillance through another local support group where I live, and doing more research, it became more obvious that this really was a good way to go. And probably within about a year, 2 years max, she was a firm believer in what I was doing. And then after that, she became a extremely firm believer in what I was doing, and that it was, she even shared some of the resentment that I had for my original urologist slash surgeon's anxiousness to get me on the conveyor belt and take care of this. And here I am 14 years later, with a PIRADS 1 of multiple MRIs. And just like Mark, there's a serious question whether I even have it. So again, the hardest part was the family part of it, the initial C word, and then having to work our way through that and educate everybody.
Yeah, Mark, if I could, I need to give my wife a plug, since you guys, and Jim Sims said, this is a couple's disease, but my wife supported me from the very, very beginning. But I got to tell you something bizarre. This first visit to the urologist, the guy had me drop my, get in a gown, drop my pants, and get into the position, assume the position, and get the biopsy. And he didn't, my wife and I, it happened so fast, my wife got to witness my first biopsy. She didn't hold my hand, but she was there. So she has been a total supporter. She's been a rock for this. And as Mark and Bill point out, a lot of spouses are dubious. Now, I don't know if they're tired of their sex lives and are willing to risk that, or they're concerned about the long-term health and the cancer is going to get you. But my wife has been a total supporter of this. So I'll shut up. I'll stop boosting my wife there.
Yeah, well, thank you for that. I did want to say too about this discussion about family members, about spouses. We've come a long way with active surveillance, and by the way, primarily due to all of you raising your voices and saying, do I really need to have this radical prostatectomy? But there's still pressure. And the pressures on people choosing active surveillance are caregivers, family, spouses, and also anxiety. And truthfully, when I thought about this webinar, I'm hoping that to keep it somewhat lighthearted, because there's a lot of unnecessary anxiety, and I really hope we can hear from those of you that are maybe tied up with anxiety. Most of us that are speaking here have reached a place of peaceful vigilance. I don't worry or think about my prostate cancer at all. And there'll be all kinds of different levels of worry, but most of it unnecessary. And that's what we hope we might help you with today. But I wanted to ask Govinda if he might speak. And Govinda is a really important part of our little group here today because he's one that successfully made the transition from active surveillance to treatment. And we at Active ASPI, we're not at all opposed to treatment. If you need treatment, get treatment. Let me repeat that. If you need treatment, get treatment, but be sure you need treatment. And there's a couple of the board members that have had treatment, and Govinda is one of them. So let me ask Govinda if he'll speak now.
Yeah, of course. As Mark said, I'm a little different from the other speakers because when I was 72, about 7 years back, I was diagnosed with prostate cancer. As a part of a normal routine, yearly checkup, they found the PSA has gone up compared to 2 years back considerably, and the biopsy was done, and biopsy results were Gleason 6, and I was given 3 choices: either you go for active surveillance, or surgery, or radiation. All 3 were on the table, and as you can imagine, most of the people around me, including my wife, my daughter, who is a medical doctor, everybody thought surgery was the best thing to do. The logic was that there's a problem, you do the surgery, the prostate is gone, the problem is gone. But unfortunately, it is not as simple as that. So I took the decision to go on active surveillance for some time. So I was on active surveillance for about a year, and I used that year to find out more about the options available. About 7 years back, the options were limited in the sense that today there are different kinds of radiation, hormone therapy, so many things. But at that point of time, it was not there. But during my research, I zeroed upon what is today called SBRT, or CyberKnife, because from my research, the idea I got was that for a normal radiation, it will be the chances of having a serious post-operative side effect was up to 30%, whereas in SBRT, it comes down to about 5% or so, because it is more focused, more accurate, and large doses in small sittings. So I was more or less determined that if I have to go for a treatment, I would like to go do that. After about 1 year, another biopsy was done, and the PSA has gone up considerably higher, and it was rated as Gleason 7, intermediate risk. So I was told that I have to choose a treatment. I talked about to my radiation oncologist about SBRT, and I was told that in Canada, the Canadian health system, OHIP in Ontario, doesn't approve SBRT. It is not an approved treatment, and I can't get it. Then I had to go back to my doctor and told him what is the way to get it. Then I found out that SBRT was being successfully done for the last 4 or 5 years at that time in UK, in India, in other countries. Then finally, my doctor told me that the only way you can get the treatment is to get into a clinical trial which is being done, that is called PACE, P-A-C, which is a randomized trial. That means you sign up for the trial, 50% of the people gets the conventional radiation treatment of 33 or 35 sittings, and the other 50% gets the new treatment, which is only five sittings and a much higher dose. So I signed up for that, and fortunately I was selected for the new kind of treatment. And that was about 7 years back. And today, after about, today I'm 80, and My side effects are minimal. I lead a normal life. But the most important decision I say I had made, according to me, is the decision to go for 1 year of active surveillance, because that gave me time to go into different procedures available in case I had to go for a treatment. It gave me time to get my personal and professional life arranged properly in case I had to go for a treatment. And it gave me time to become accustomed to the idea that I have a disease like cancer. Because when you are first told that you have cancer, the first question that comes to your mind is how long I have got, rather than anything else. And I felt in the first few days or few months, you are not in a position to take a proper balanced decision because your emotional turmoil. So it is extremely important that I got that 1 year to get the time to go through all these things. And another important thing is that if, in my opinion, you should delay your treatment as long as clinically possible. Because every day, new treatments, new treatment protocols, advancement of treatment, these are coming up almost every other day. So the more you delay, the more likely that you will get the better treatment with less side effects. So I feel that it's extremely important to take active surveillance as much as possible, even if you have to go later on for a treatment. It gives you time, it gives you mental peace, and you are reconciled to the fact that you have to live with something like cancer. Because whatever treatment you may take, irrespective of the kind of treatment, there are going to be side effects. And it is up to you to find out what are the side effects of each treatment and decide yourself what side effects you can live with and what side effect you want to avoid, depending on what stage in life you are. Because when I take a decision when I am 70, my priorities are different from a person who is 58 or 59 and who has to take the same decision. So I feel these things are very important, and active surveillance gives you time to do all these things. That is my take. Thank you.
That was very well expressed, Govinda. Thank you. And two, Throne would
Yes,
say...
Mark, over to you.
No, thank you. Throne would say, Throne is one of our founders. He's not here today, but he would say exactly the same thing. He was diagnosed in 2005 when I was, and took 13 years to do his investigation, and was grateful for the 13 years on active surveillance, because the treatment that he got was 13 years later was so much more advanced than had he done it in 2005. So his words would have been much the same as yours. And by the way, for those in the audience, I really want to encourage you to go to our website and see our award to Throne. Throne was given the Patient Advocate Award, and we have a wonderful award program. We use our award program not just to honor people like Throne, but also to convey the importance of active surveillance, and it works. I don't see Jeff here yet, so I guess that's all of us, if I'm not mistaken. Hey, Howard, can I ask you to do me a favor? Could you monitor the chat room by any chance?
Well, I can try.
Well, do what you can. I don't want the poor people on chat to be hanging up, but I also, I guess I want to emphasize something that needs emphasis. Your voice, ASPI's voice, but your voice is in particular extremely important. It's influencing this whole arena of active surveillance. Now I know that just from being in this position, but I also know it from things like the guidelines, for example, that were published by NCCN over a year ago. And the guidelines preferred intervention, preferred radical prostatectomy to radiation. Well, when we saw that, we said, where is active surveillance in this thing? And so we sent a letter to NCCN, and I'm sure others did too. But they changed that. They changed their guidelines so that active surveillance is now on a par with the radical prostatectomies and radiation. And so your voice is important, and we just want to encourage that. And that, by the way, that
Let me double check you on that. Did you, I mean, in the low risk group at this point, I mean, 13 years ago, 10 years ago, only 6 to 10% of guys opted for active surveillance. Now it's up to 60%, but it's still below the 90% plus in UK, Sweden, and the state of Michigan.
Yeah, we have a long way to go.
Yeah, and surgery has fallen to a distant third, and radiation is in the middle. And we have a question here, and I'm going to probably mispronounce the guy's name. It's either Al or Al Sajdak. And he's asking, is any treatment completely non-invasive besides radiotherapy? And, you know, I mean, this is a group focused on active surveillance, but maybe Govinda would have something to say. I mean, do we really consider radiation non-invasive? You're being invaded by rays of radiation, or being given seeds of radiation. So, I mean, Govinda, is that not?
I can take that. Radiation is definitely invasive. It is not non-invasive because it goes inside and treats your internals. So it is definitely invasive.
And two, invasive because radiation can still have side effects. We have people that have, if the radiation is not done carefully, they'll have bowel issues and all sorts of other issues. There's some studies that with radiation you might have other cancers showing up later on too.
Now, Al is also asking about statistics for bowel incontinence. I think there's, you know, this is an active surveillance group, and I don't know the answer to that. Maybe Govinda does. My sense is the bowel incontinence. I think it's declined, but does anybody know what it is?
No.
Yeah, there is bowel incontinence connected with radiation. It depends on the accuracy of the radiation, but also there are treatments where they insert a pad in between your bowel and the prostate so that the bowel is not affected. But definitely there is bowel problems, after effects after radiation.
Howard, I think the way I might be wrong, but I think the way he posed the question was really the statistics comparing bowel incontinence after radiotherapy without a gel spacer.
Yeah, you're right. There was another.
So the statistics being, you know, with or without, and I doubt there's such statistics comparing those two different methods, with or without.
Yeah, I mean, this group is specializing in active surveillance. You know, we probably shouldn't be taking on questions like this anyway.
Mark, Jeff is joined now.
Oh, Jeff. Okay, if we could backtrack a little bit, and then we'll get to your questions. Jeff, welcome. So I had asked the board. This is Jeff McLennan. I had asked the board to speak of their most challenging part of their prostate cancer journey. And, you know, just a few sentences. Would you be willing to share that?
Sure. Thank you very much. There was a I guess the word would be a diagnosis that was wrong about the cancer possibly spreading outside of the capsule, the prostate capsule. And that was re-diagnosed by who other than Dr. Epstein. And he indicated that he corrected the original diagnosis. And so that saved me a great deal of struggle, internal struggle, mental health, if you will, mental well-being. Thank you, Mark.
You're welcome. Let's go back to the questions now. Howard, you can keep your eye on the chat room questions, if you will, but I wanted, there's not that many of us here, so maybe we can try to do this if you're willing, the audience is willing. Just unmute yourself if you have a question.
Or raise your hand, and we can take that. And that,
well, when you say raise your hand, you want them to raise their hand through.
Yeah, just like Jim McHugh just raised his hand. So I think we could turn the floor over to Mr. McHugh.
Okay.
Thank you. Yes, I'm asking if you have heard of a new liquid biopsy called Sentinel by MIR Scientific, for whom the chief medical officer is Dr. Lawrence Klatz. I've been following it for about 2 or 3 years, and it is on the market. I've asked my urologist about getting the particular liquid biopsy because it's apparently 90 to 95% sensitive and specific with regard to indicating if you have prostate cancer, and if you have it, whether it's low, medium, or high risk prostate cancer. After which, if there is that indication, you could go ahead and have a needle biopsy. But it's a way of avoiding a needle biopsy, which I have been trying to do, but I'm getting up to a point after 10 years where I may have my 3rd biopsy. I have been resistant to biopsies, and my PSA over 10 years has gone from 2.7 to 6.3. Which I feel comfortable with. So has anybody heard whether or not the Sentinel liquid biopsy is available and if it's been successful?
There's a lot of products out there. And I mean, the Sentinel is, for example, not available in New York State. I knew somebody who was from New York who was trying to get it. But, probably more pertinent as far as the way treatment trends or diagnostic trends are going, Jim, is whether, are you monitoring with MRI? Because there's generally been a shift to using MRI as a way to determine whether to do a biopsy. MRI is good at finding suspicious lesions. It's not so good at finding small ones, but that's actually a good thing. So, Jim, let me throw the question back to you. Are you monitoring with MRI?
I had a trust biopsy first, and then a few years later, I had the MRI followed by
that happened to me too. But that's it happened to me 11 years ago, and that was before MRI had caught on. Right now, sort of the standard in academic practices is they do MRI first to determine whether they want to do a biopsy. So if you've had MRI, have you had a recent MRI?
I haven't had a recent one. It's getting to a point where I probably will.
It's probably the best way to go. I mean, you could probably get the Sentinel test if you wanted to, and there's other tests out there too. But personal, I'm not a doctor. I don't play one on television. But if I were you, I would kind of seek out another MRI. As much as I personally hate MRIs, I get claustrophobic.
Well, and Howard, just to add to that, to make sure that you get a multi-parametric MRI from a center of excellence or someone who is experienced with prostate cancer imaging, because you want to make sure that someone is has a lot of experience behind them, where just a generic person doing a generic MRI most of the time may not give you the report or results you really, should have.
Yeah.
I had my MRI done at the University of Chicago. It was quite a while ago, and I am due for one soon, but I'm hoping to get that liquid biopsy first. My urologist indicated that his colleagues from around the country have not used Sentinel, and he's thinking that if it's supposed to be such a great thing, why aren't more urologists using it? And I'm asking if anybody is aware of it being used and how successful it's been.
There's a lot of skepticism about it, and skepticism about the numbers. By the way, Jim, I had my first MRI at the University of Chicago, and here's a warning to all of you: make sure that the hearing protection is secure, because mine came loose and I ended up getting tinnitus as a result. I mean, I can still listen to my MRI from 11, 12 years ago at the University of Chicago. And here's another pointer: if you have an MRI, try to go into the machine feet first. Keep your head away from that sound machine that they have there. That's for free as far as advice, and I think it's appropriate.
I'd like to also add, Jim, that my PSA was somewhat reconsidered because I am diagnosed with a larger prostate. They call it BPH, and that does have an influence on your PSA testing results.
Right.
So we should probably move on to the next question. We have Michael Wynn, who's put his hand up. Michael, would you like to ask your question?
Thanks, Bill. Good morning. I know that for people that have Gleason 3+3, it's fairly reasonable to go to and continue active surveillance. What about people like me? It's sort of like a median point that I have 3+4, and the pattern 4 is about 20%, 2 sample out of 25. So the question I have for the people here is that anybody who have pattern 4, like 3+4, and has been in active surveillance for some time.
Good question.
Govinda, how long were you on active surveillance?
I was at active surveillance for only 1 year. Mine was Gleason 6 to start with. Then after about a year, it became Gleason 7, 4+3, and then I decided to go for treatment.
Anybody else with the?
Tony wants to do.
Tony, if you want to answer that question, you'll have to.
Oh, I'm sorry, I wasn't answering the question. I had a question. I'm sorry.
Let's stick with this.
Let's
for a
stick
while.
with Michael Wynn.
Yes,
Go ahead.
Well, there's another. Al, if he can speak up, says he's been with 3+4 for over a year. I wonder if Al could speak up and say what percentage invasion he had, and then we could go to Brett.
Well, I'll go to Tony.
Or Tony. Al's not speaking up.
Unmute yourself, Al.
Okay, can you hear me?
Yeah.
Can you hear me now?
Yeah.
Mhm.
Yeah, I didn't hear the question.
Mike Wynn from Denver was asking about the experience of other people with 3+4. You mentioned in the chat box that you have been on active surveillance for over a year, but you didn't say what percentage and how many cores were affected. Are you able to share that?
Yeah. Just to be clear, I've been on active surveillance since 2017, and my PSA hasn't changed from like 5.7 in 2017 to just recently a 5.9. As far as the cores, they did 12 cores. I'd have to go digging for the percentage. I want to say 20% in one core, 10%. There were three cores, they found three areas. I think it was 20, 10, and 60%. I'd have to go check. If you give me a minute, I'm sure I can
Well,
find it.
so Al, were any of those 3 plus 4?
No.
Okay. Well, that's kind of the crux of this current question, was anybody who has been diagnosed with a 3 plus 4 Gleason.
That's me. I've had 3 plus 4. Maybe I'm not getting the correlation, but I currently have a 3 plus 4 Gleason for over a year now, because that's documented with the biopsy I had.
Okay. So Michael, could you refresh your question relative to the 3 plus 4?
Yeah, maybe you have to do that.
Well, maybe Mike can ask him directly.
Yeah, let me repeat the question again. Is that essentially I have a 25 course
25
biopsy at University of Denver. It's a center of excellence. And essentially 2 of the cores show up to be 3 plus 4. And the pattern for a 20%, it is confirmed by Dr. Jonathan Epstein before he went on his sabbatical. So I asked the folks that anybody who have biopsy with the pattern 4, like 3 plus 4, not 4 but 3, but 3 plus 4, and what the percentage of pattern 4, and whether the person had been in active surveillance for some time. I have been in active surveillance for 2 years with 3 plus 4, 2 of them with 20%.
Okay.
Okay, let me go look.
Bill Cody just put in the chat room that he can answer that question, so I think we should let him have the floor.
Okay, thanks. Yeah, I've been on active surveillance for 7 years, and initially with the biopsies and MRIs and everything. So it was 3 plus 4 equals 7, and intermediate grade 2. And so fast forward to just last month, I had another MRI, PSMA PET, and biopsies again. Extensive workup on that, and it still came back 3 plus 4 equals 7. My PSA is about a little over 10. However, they said, the size has increased a little bit. They're concerned about some extracapular extension, although they're not really clear on that. The MRI said that there might be, and but the PSMA PET said that there isn't to the seminal vesicles. So now the only thing that's other than getting a little bit larger, the only other thing that they indicated with the last biopsies was there was what's called cribriform present, which I understand seems to be could be a more aggressive indication of.
Do they indicate the level of cribriform? I mean, is it high or low?
Low.
Yeah, I mean, if it was high, it would probably be more worrisome.
Bill, can I follow up with a question for Bill Cody?
Certainly.
What's the percentage of pattern 4? Because I talked to Dr. Lon Klotz and also Dr. Jonathan Epstein. If you're less than 10%, you are reasonably going to be considered to be active surveillance candidate, but you about above 20%, and I'm right at 20%. He said that I take some risk. Even though I have the Decipher test, so very low risk, I have PSMA PET scan, and it's showing no, everything inside the capsule itself. And last but not least, essentially, my PSA had been steady. So, Bill, do you know whether your pattern 4 is less than 20% or 10%, or what the percentage of pattern 4?
Honestly, I'd have to dig that out to answer that question. I did have the Decipher, you mentioned that, and it seemed to be just a little bit higher than the median, pushing me just basically into the higher risk. So you know, I think we're both at the same place as to what to do. I did have kind of a relative question of the one gentleman. This is relative to the discussion now, that was misdiagnosed, apparently said that it had spread outside the capsule. He mentioned that he had further diagnostic done that indicated it wasn't. I was wondering how that was established, what was used to establish that it wasn't outside the capsule.
Yeah, what we did is that essentially we insist on PSMA PET scan, and that had helped me with that particular data point to show that essentially the cancer is, essentially never spread outside the capsule itself.
Can I say, I got the statistics now. As I said, I had 3 places, all grade 4. One was at 20%, one was at 10%, and one was at 40%. And this was a year ago. And
Thank you.
The doctor, my urologist, I went to get a consultation from 2 radiation oncologists. They wanted me to get the radiotherapy because I did also visit a surgeon and I just didn't feel comfortable with surgery. I'm 71. I didn't feel comfortable with surgery. And I also have diabetes, so I have comorbidities. But I am entertaining getting radiation therapy, but I'm just concerned about when I said invasive, I meant like needles and implants. I know it's invasive, as Govinda said, but I'm leaning towards radiotherapy, but I just loathe the fact of possibly getting bowel incontinence at my age. That's what's preventing me from getting it. Plus, I have no symptoms whatsoever.
Yeah, can I answer a part of your question? While doing SBRT, at that time, they implanted 4 gold beads into my prostate as a marker to locate the area of Gleason properly. And that remains with you throughout your life. It doesn't come out or they don't take it out. And that is inserted through a procedure similar to a biopsy.
Well, I recently read that with the fiducial markers, they are no longer needed because they have this MRI-guided, radiotherapy.
That is correct, but that is available only in limited center of excellence facilities, not everywhere.
Okay, so in other words, my question was, including my definition of invasiveness, there's no treatment other than radiotherapy without the gel, because that's done via needle in your perineum, which freaks me out. There is no other totally non-invasive treatment for my level of prostate cancer at this time. Is that what you're telling me, Govinda?
No, I don't know about the other treatments, but at that time, this putting the gold beads into your prostate was there. Today, it's possible without the beads in that particular machine they have. So that could be non-invasive in your definition.
Okay, yeah, it seems that with I think they call it the ARC or something in New York, like Sloan Kettering has certain radiotherapy that doesn't require these markers because, again, I don't want anything in my body. I wouldn't mind getting the radiotherapy because it's like an X-ray, and with stereotactic, it's maybe 2 weeks with 5 treatments. I don't know the exact, but it's short-lived as far as I'm concerned. I'm leaning towards that because, like Michael Wynn said, I have a high percentage of grade 4 in 3 spots.
Yeah, it's actually 5 treatments in 2 weeks. And each treatment will take only about half an hour or so. You go in, you have the treatment, you come out and go home.
Yeah, that sounds appealing, but I still am on active surveillance because, as one of you said, I think it was you, Govinda, just wait a while. Things are changing. Even 2 years ago, things are changing so fast.
Absolutely. Another plus point for being on active surveillance as much as possible is that during during the one minute, please. During that time, you will know about better diet, more exercise, and you do that when you are in active surveillance. If you have to go for treatment, that helps you a lot while taking a treatment.
Oh, thank you. Okay, so exercise and eating right. Okay.
I think we ought to move on to some
Yes.
other area, don't you?
Tony should go next. He was the next in line.
Well,
then we
first
should
off,
hear-
I appreciate everybody being here and what you're doing for us. I really appreciate that. Thank you. And I'll start off with a little history. I was diagnosed 6 years ago. My PSA was 5.86. First option, doctor wanted to cut it out of me, and we just didn't like the doctor, so we said no. And I found a doctor that said active surveillance. My PSA gradually grew and grew up until last year. It was around a little less than 10, but this past year it's gone up to 19. And I had an MRI with a guided biopsy, and I went from a 3+3 to a 4+3. And I don't know the difference between a 4+3 and a 3+4. I think there's a difference. I'm not sure. That's the question I'm asking, is what is the difference? And has anybody ever heard of the T called ESSIAC, ESSIAC? And if you have, if you're using it, if you have any report on that, then
let me just respond to your first question. I can't respond to the second one, but the first one is, what is the difference between a 4+3 and a 3+4? That just indicates that you have more predominance of 4 in your prostate, which generally, if you're a 3+4, you're a candidate for active surveillance. I actually don't know anyone offhand that is choosing active surveillance with a 4+3. I mean, active surveillance is about low-risk prostate cancer. And once you get to a 4+3, that begins to not be low-risk prostate cancer
Now,
anymore.
Mark, I should interject. At University of California, San Francisco, they did a study which they put out last year, which I could dig up. And some people, they let people follow to some degree what they wanted to do. And some 4+3s were going on active surveillance.
Wasn't aware of the study.
It's uncommon, but, it happens. It may not be advisable, but it happens. Some of it is a function of our age too, especially if you're older, in your 80s, maybe you might just let it go on watchful waiting. Bill, I'd like to pick up on one or two questions that come in through the chat. And again, if you can add where you're from and if you can tell us how old you are, it might be of interest. Chris Busby from Ottawa asks, and I don't know how old he is, but it doesn't really matter. What is the status among urologists about now terming Gleason 3+3 cells cancerous? I've been personally involved with that. I've written co-authored some of the big articles with the doctors about it. And as it stands, well, first of all, the argument is this really cancer? And it depends who you talk to. And certainly 90% of pathologists will call Gleason 3+3 a cancer. It looks like a cancer. The urologists are split in half, 50-50. They say it looks like a cancer, but it doesn't act like a cancer. And top people in the field like Dr. Egner and Dr. Klotz and Dr. Cooperberg say, it looks like a cancer, but it's never by itself going to evolve into metastases. Gleason 6 is never going to kill you. But you still want to monitor, because even though that part of the prostate is Gleason 3+3, more advanced prostate cancer can develop. Now, I did a survey, or I led a survey of men 450 men. And actually, I heard yesterday that the Centers for Disease Control has approved funding for a follow-up study. One of the problems with this is we have done a lousy job of attracting minority men into active surveillance for a variety of reasons. And so CDC is going to pick up on the questionnaire that we developed, and they got funding, which is like a miracle, and it only took 9 months. And so we're going to know more about this, but at any rate, in terms of moving the needle, no pun intended, as far as Gleason 6 being defined as a non-cancer, there are negotiations going on now between urologists and pathologists over whether there's some way to kind of be more specific with it, and not necessarily say that you have a cancer, but say, that it was once considered a cancer or something like that, because two issues come up with this. Emotional distress. A lot of guys get very upset just from the C word. And thing is the C word's not going to kill them. It's going to be heart disease in the end. And also there's financial implications. I personally have had that. I was unable to get insurance at a favorable rate because I had a Gleason 6, and it depends on which insurance company, but 7 company, I'd always had favorable rates. I got diagnosed, and next thing you know, 7 companies wouldn't re-up my insurance. I spent, it was like $600,000 worth of term life insurance, and I was spending, I think, $200 a month. Eventually, my own insurer agreed to insure me, but they cut the $600,000 down to $100,000, and I'm still alive 13 years later. So I could have done better, but I'm going to put in the chat to everyone an article I co-authored on this debate, and it's ongoing. And there may be some changes in the way that pathologists, diagnose us or just, report out on this. But my former urologist, Dr. Egner, said this is a life or a career goal for him is to change this. He told me that 13 years ago because he didn't really consider it cancer. I don't know if that answers the question, but here's a question from the chat for Mark, and then maybe we can go to some of the raised hands. John Best, we don't know where John is from. He's been on AS for 3 years. He has an enlarged prostate and has urinary issues. His doctor put him on Finasteride to shrink his prostate. And of course, that reduces your PSA about half, so they have to double it. He says, I have my next visit with the urologist in a month. What should I expect on my PSA? It was up to 9 5 months ago. Anybody have experience with this scenario? So the prediction, John Best, is it'll probably be 4.5, but maybe Mark or Dan Dressen can address this. Mark or Dan?
I'd be happy to start off in addressing it. Urination issues are an important part of what we do as well. In fact, for me, the urination issues are much, much more important than the prostate cancer issues. Where's the next toilet? The urgency. Can I get it out in time to go pee? Those kinds of very fundamental issues. And it was kind of interesting because the other day, just a couple of weeks ago, I was sort of complaining to my wife about this, and Wendy said, well, you drink about 5 cups of green tea every day. And so green tea is helpful with prostate cancer. So there was a reason that I was doing it. Well, I quit drinking green tea, and most of my urination and the urgency issues went away. It's not entirely solved, but it got a lot better. Now, let me come back to the finasteride issue. Years ago, I was on finasteride, but I found it had other sexual implications. I didn't have a drive anymore. And so I got off of that. But it is interesting in terms of the story that I just told about what Wendy said to see that, yeah, there's pills, there's ways to treat BPH. Well, in fact, in my case, I had green laser therapy, and I had a TURP, very old and well-established procedure. None of that stuff on a long-term basis solved my issue. In fact, stopping green tea solved my issue more than all of those other things solved my issue. So I'm not sure that the medical procedures are the best process. Interestingly, because I'm looking for some feedback too here. Interestingly, I just read something. We get all this promotional stuff on the internet, and what's real and what's not real. Well, this promotional thing, I just listened to it, and it was on bladder fungus. It's kind of like a male candida, if you will. And so with this particular diagnosis, the urine sits in the bladder and then creates a fungus in there, and that causes all kinds of urination issues. Now, and so they were selling a product to deal with the bladder fungus. I didn't get a chance to research it, so I haven't done anything about it. I guess I'm asking all of you out there, did any of you hear of this notion of bladder fungus or male candida or anything? Anybody hear of that? Nobody? I'm the only one?
It's usual.
I saw it on internet. I saw the advertising.
You saw it too? Yeah.
I didn't buy any, but I saw it.
Yeah. Well, I thought it was interesting. It's an interesting theory.
I've got enough issues without worrying about a non-issue.
It could be a non-issue. Yeah, that's why I usually research this stuff more.
Yeah.
And I never just buy it offhand. But anyway, let's go back to
Dan.
Move on.
Dan knows a lot about finasteride. Dan?
Yeah, I've been on active surveillance for about almost 6 years now, but initially I was put on finasteride because of an enlarged prostate. My prostate wasn't really that large, probably about 50 cc's. And I was happy to do it because, there's finasteride like 5 milligrams a day. Propecia, which is what people take for hairline, is 1 milligram a day. So my hair could use some extra hair. So I was happy to take it. But then after about 2 years, I noticed I had some breast enlargement, called gynecomastia. And that's one of the offsets. What's one of the things that could happen from the finasteride, but it's very unlikely. I think gynecomastia only happens like less than 1% of the men who take finasteride. But there's other things. There's something called post-finasteride syndrome. I think if you look it up, I think it has the potential to cause all kinds of other side effects. One of the other side effects is issues with memory. I'm 71 years old now, so basically I'm in that age group where I very likely have issues with memory, but I didn't want to take any, because of finasteride has the potential to cause memory issues. I'm now taking less finasteride. With my doctor's approval, I'm only taking about a milligram and a half a day.
So Dan, the guy was asking what he can expect when he goes in. So do you think he would expect that his PSA would be down about a half?
That's what happened. That's what happened to me. My PSA was cut in half, probably within 6 months from when I started taking it. It was cut in half. I've been monitoring it, and it was cut in half just as expected.
So maybe it's time, Bill, to move on from finasteride and You
Right.
know, who's next?
William Jones has got a chat question and his hand up, so I'd say he's next.
Thank you. I'm scheduled for a third biopsy early in the first week in December. My urologist is sort of more treatment. He's an expert surgeon. And my question to all of you is, I've been on active surveillance since 2018, and had two biopsies, 2018, 2019. They indicated 4 cores that were cancerous, 1, 3, 3, and 3, 3, 4s. So, and then I had a genetics test, Prolaris, that came back that I was in the bottom 16th percentile, I guess. So that was good news. But then another one came back later that gave the opposite result, that I was in the that 65% of the people were. So basically, that was I would call that inconclusive. My PSA has been. You guys are talking about PSAs up to 16. Mine has never been above 6. And I have a volume of prostate around 77, 78 cc. So, and my MRIs, I've been doing PSAs every 3 months, and they've really been in a really narrow range, from a high of 5.8 back in 2018 to a low of 3.73 after I had substantial weight loss, to the latest one is 5.5. And it's been basically bouncing around in a very tight range. Like I say, never above 6, never below 3, average in the 4s, which normalized for the size of my prostate would make it normal. So, and then MRIs have indicated no spread. I've had 3 MRIs, and they've. So the question is. The last MRI actually detected a little polyp, incidentally on the bladder, which I had a rigid cystoscopy to remove. And the recovery for that was the most painful thing. I've had a kidney stone before. This was far more painful. It was just excruciating. But no, there's been no return of that. I'm doing another flexible cystoscopy now, he wants to do the flexible cystoscopy second time, along with another biopsy, and I'm inclined to make it this time transperineal. I share the squeamishness of other people about that, but it seems to be much less likely to lead to infection than the transrectal biopsy. But the question is, do I need a biopsy at all? We already know I have cancer. Are there other ways to detect? Are there equally good ways to detect whether it's spread or not?
MRI would be a good. When was your last MRI?
It was. Let's see. Let me see my notes here. 2021. So about 2 years ago, a little over 2 years. So
why not do another? And let me ask you: is your doctor based in an academic setting or in the community?
Well, he's at the University of Washington. His name is William Ellis. He's very well respected as a surgeon. What's that?
Well known, yeah.
Yeah, very well respected as a surgeon. So I had a 5-month stay as a visiting professor in Berlin. And when I got back from that was last spring and into the fall. And when I got back, I said, well, it's time for another MRI, I guess, and I'd like to schedule that. And his assistant came back and said, well, Dr. Ellis is quite insistent that you need to have another biopsy. And I said, well, if it's a fusion biopsy, don't I need an MRI to go on that? And he said, no, we can use the results of your previous MRI from this 2022, 21.
You might get another opinion, even like from Dr. Lynn. I think it's Lynn at University of Washington, and ask if you really, if you could just have another MRI. I mean, it's been a couple of years, and it would indicate, whether it could be an indication of whether you need a biopsy.
I agree. I'm feeling like Dr. Ellis is, he's very well respected as a surgeon, but that means maybe, if you've got a hammer, everything looks like a nail. I don't know.
Well, all of these urologists are surgeons.
Yeah. But in any case, it's just I don't think we're collaborative anymore with respect to this active surveillance, and so
I would see if I could switch to Dr. Dan Lin.
Dr. Dan Lin, okay.
Yeah.
Yeah, it gets a little bit tricky into, do they get if I eventually have to go to get surgery from Dr. Ellis, is he mad at me for that?
Is he going to get revenge? They're big. They're big boys and big girls.
I would hope so.
You got to look out after yourself, not their egos.
Yeah.
Well, and they will. The medical system is going to err on the side of overtreatment. Now, you have no liability concerns. You're not going to sue yourself.
Yeah.
And they're encumbered with liability concerns. And so, we've all had situations where the system is trying to do more than it needs to do. I mean, in my case, I had an MRI and it was a Pyrades 3, and the doctor said, you need a biopsy. And I said, no, I'm not going to get a biopsy. And Pyrade 3 just means it's ambiguous. It doesn't, that's all. If it were Pyrade 4, maybe I would have considered it. I don't know. But even the Pyrade, by the way, Pyrades are not always totally accurate, but that's not the point that I'm making here. The point
Mark, nothing's totally accurate. I mean,
well, really nothing's totally
accurate. 20% error rate with biopsies, also with MRIs. They're misreads.
But my question for all of you, sorry for interrupting, but I just why do I need I'm back to this. I don't want to get well, first of all, if I get a biopsy, is there general consensus that transperineal is probably better?
Let me answer that question.
Okay.
It depends who you ask. If you were back in Germany or you were in Sweden or UK, chances are the transperineal is what you would have. The European Association of Urologists last year said that transperineal was the way to go. If you were in America and you went to the American Urological Association, they recently elevated transperineal to be up to the same level as transrectal. But the American doctors are lagging on this, and there's bias. I mean, I have a couple of cousins who are urologists in LA and also at UCSF. And, I created a petition calling for basically a ban on transrectal in the United States. I mean, a certain number of people die from these things. Sepsis.
They get sepsis. Has anybody here had a transperineal biopsy?
Mike has.
I have.
Generally.
What was your experience, Mike?
First, I'd like to address the question that William Jones, you mentioned about that. I actually have two separate urologists separately, one from the university in Denver, and the second one a commercial outside. Both of them are very highly qualified. They kind of know each other, but they're very highly qualified doctors. And similar to you, I have an MRI and a transperineal biopsy twice. The last one in March 2022. So I would call by the University of Denver that, hey, you need to come out and have another MRI and a biopsy, because by NCCN, that is yearly, you need to get a biopsy. I delayed that because I consult with the second guy, and he said to me that, well, for all it's worth, he said that university tend to be by the book. They like to go to and do every year biopsy. And so I delayed it until next year and still studying the issue right now. So that's for your information. I mean, essentially, university tend to be a little bit more kind of very I don't know, liberal in their interpretation of the requirement. At the same time, by the way, I used to be a professor of engineering in University of Southern California. So I know the system quite well. I mean, they really do it by the book. To answer the question, transperineal biopsy, the first two that I have, one in 2019 and one in 2022, they put me out completely. But because my son is an anesthesiologist and my wife a medical doctor, at my age, I'm just turned 72, they said, well, just see what the gentleman that you are going to go to and have a transperineal biopsy in April next year, whether he can do without anesthesia. He convinced me, he said, yeah, I'm going to take only 12 samples and they're going to be local. So my son said to me that, well, see what kind of anesthetics you're going to use, whether they're fentanyl, whether they're going to give you a Valium, whether they're going to go to and do what need to do, because in fact, anesthesia does carry with it some risk too. I mean, essentially, you know, you can have memory issues, you can have things that stick in your either brain or maybe your liver. Because my son, when he does, some people at old age, they normally check for several parameters in the kidney called BUNS to see whether your kidney function, whether it's okay or not. So anyway, for what it's worth, my experience at transperineal was pretty kind of bloody, because the first two, when I went to sleep, they did a saturated biopsy both times. Even though I negotiate with them, I said, get the very small number sample, but when you sleep, you didn't know whether he took 52 samples the first time and 25 second time, were bleeding, and it was horrible. I got, you know, Foley catheter for days, and it was very painful. And the semen and urine got bloody for weeks. Anyway, for what it's worth.
Yeah, Mike, let me interject that there was an old style transperineal that was borrowed from, I think, radiation therapy for brain cancer. They put them on a stool and they had a template and they would follow the template. There's a more modern approach called precision point. And with that, it was designed to be done in the office, but it turns out in the United States, first of all, it's hard to get a transperineal. Second of all, I don't think they ever expected this, but the men are split about 50-50, although there's more of a tendency to ask to be knocked out to get a transperineal. Especially newly trained doctors prefer to have you out like a dummy, and because you're not going to be squirming. Just to give a counterpoint to what Mike said, I know guys that have had it awake, and they said that it's initially there's discomfort, but once they apply the local anesthesia, that kind of disappears. It's a few minutes of discomfort. But the way it looks like it's going to go in the U.S. is more men are going to be knocked out. Of course, that costs the system more money. It involves some sort of anesthesiologist. There's a third path that's being done with laughing gas, but that's even harder to find, where you self-administer the laughing gas, and you're so oblivious to the whole thing. But there was somebody else here.
Can I follow up with what Howard mentioned about it? Real quick, the first thing is that several people, including my son, said that what you want to do when you go for local anesthetics, just make sure that they wait for at least 5 minutes so that the anesthetic will be, effective before they go to and do your biopsy. So that's something that you want to go to, because some urologists tend to go to and right after they inject that anesthetic, right away they come in and, essentially poke your perineal, and that can be very painful because anesthetic didn't take effect yet.
Mike, aside from blood afterwards, first of all, I'm astonished that you had 52 samples. I've only had, with the last fusion biopsy, I only had 12, I think, 6 targeted and 6 exploratory. But aside from that, was there pain in the aftermath after during your recovery period?
Yes, it's quite painful. Essentially, that the risk that essentially you submit yourself to the university or academic. Sometime unbeknown to you, I wasn't, I guess, in university before. Sometimes they do it for their research. So they do saturated, they not only at the target area, but they do all around that. And essentially it can be very, very uncomfortable and painful for weeks.
They didn't advise you ahead of time that they
No.
want to do that?
No.
Seems
That's not a
unethical to me. But my bigger question is, is a third biopsy even needed? They already know that the cancer is there. Are there other ways to detect whether it's spread or not that are equally sensitive?
MRI. Get an
The
MRI.
MRI, yeah,
Right.
that would be the most logical and the least.
Well, no,
least side effect.
and now there are different. You talked about different kinds of MRIs. Is there a more sensitive MRI?
Well, there's the 3 Tesla MRIs, but generally people don't feel like you need a 3 Tesla MRI.
Well, actually, there's a 1.5 Tesla. The newer machines get an equally good result.
Exactly.
We also
here
have
at the University of Washington, it's pretty decent. One of the world's experts on this, Dr. Westphalen, is based there. I refer a lot of guys to him for second opinions. Bill Cody said he has some comparison, if we want to call on Bill, but maybe, I think are we heading towards quit time, or are
we are, but let's deal with these hands that are up.
But just to conclude, then, if I could just wrap up, because this is an imminent decision for me. It sounds like maybe I need another urologist, or at least a second opinion.
Yes, we need a second opinion, absolutely.
And then it might.
And I can put you in touch with Dr. Lynn personally.
Can you? I would appreciate that. And then it might be that MRI is equally sensitive to a biopsy.
Okay, I'd like to jump in here. There's a PSMA
one second first. William, I put a note to you in the chat, and you could respond with your email, and I can introduce you to Dr. Lynn.
Thank you, Howard.
Yeah, Bill
Cody, Sacramento area, UC Davis. A couple of things. PSMA PET scan is the newest and supposed to be the best. It's the same procedure they're using. They induce a radioactive tracer in you, and which they're also using to treat cancer spots. The PSMA PET is put in there, and then you also have the typical MRI or the PET scan, and they overlay the two, and then that is supposed to be the newest way of detecting if cancer is spread outside.
That's a good suggestion for William Jones.
Yes,
is to check out the PSMA. It is really, at least at the moment, aimed at guys with 3+4. Some guys with 3+3 have had it. I'm going to give a plug to myself. I do a newsletter called theactivesurveiller.com, and I have an upcoming, I've started to have these expert doctors comment on this, and I'm going to have Dr. Westphalen coming up, I think, on the 15th of December. He's going to be talking about why there's hesitancy about doing this with Gleason 6. But, as Bill Cody pointed out, 3+4 would be a good thing for William to ask about.
So if you wanted me to follow up just quickly on the MRIs, I had 7 years ago, the transrectal seemed like a piece of cake, really with just local anesthesia. About 2 months ago, I had the transperineal one, and it was horrible. Local anesthetic, the induction of the local anesthetic was very painful. Even after that, the actual biopsies were very, very painful. Afterwards, I had a great deal of pain for quite a couple of weeks with in the rectum area, and then I had expected blood in the urine for a couple of weeks, but I had actually had blood in the semen for in excess of probably just up until a week ago. So that would be over 3 months, I guess. So that's my experience on the two.
Yeah, I don't know that that's necessarily the typical experience, but appreciate your sharing that. I don't know if there's anybody else in this group who's undergone transperineal that have similar complaints to Bill's.
I've heard of such complaints, but also there's many. I mean, in Europe, this is what they do, and so it can be done without all of these side effects. We have actually
Bill Wood from Ontario had a question.
Yeah, we want to take maybe these last two and then wind it down.
Yeah.
I had a transperineal in March without just with local anesthetic. We took 10 cores. It was a targeted biopsy, and the only trouble I had was pain in the anal area during the procedure, and about a week or so after. Apart from that, nothing at all. And I suspect maybe the pain in the anal area was maybe because of the size of the probe they used. I didn't see it, but my anus was quite sore during and after, and about a week or so after the procedure. But I had no more bleeding or any side effects that I had previously from the transrectal. So for me, it was no trouble at all. I'm 82. It was just a local anesthetic. It wasn't a problem at all, except for a bit of anal pain.
So there you have it, two sides of the anus there.
Howard, you should have my email. I sent you my email address.
I immediately after this, I will introduce you to.
Well, yeah. Let me just say it's actually we're about ready to run over, but let me make a couple of pitches here. We appreciate you. We may take one more question. I'm not sure, but let me make a couple of pitches anyway. So ASPI exists for you and with you, and without you, we don't exist. And so we're volunteers here, and we're volunteers because of our deep commitment to this process, and we think it needs to be shouted from the rooftops, and that's why we do these webinars. And so we are actually looking for a part-time bookkeeper, maybe 5 or 6 hours a month. And we're also looking for people that have fundraising experience. And so if any of you have those capabilities, please get in touch with us.
Hey, Mark, does fundraising experience relate to making donations? Is that what
Yes.
Well, that would be good. And two, by the way, one of our board members has agreed to match any funds donated up until December 21st. You're all familiar with the qualified charitable distributions. If you have an IRA, you have to take your required minimum distribution by the end of the year, otherwise you pay taxes on it. But if you donate it to a nonprofit like ours, then you don't have to pay the taxes. So give some consideration to that matching opportunity as well. Shall we take one more question? I think there might have been one more question left. Was there another question? Maybe.
I think we got him.
All right. Well, that's good.
Okay.
Well, maybe we'll end with a thank you to all of you. I enjoyed today. I enjoyed all the questions, very good questions and good responses. And we're very good at not giving medical advice, so nothing we said was medical advice. So I think we'll close it out. And if the board could just stay for maybe.
And I mentioned William Jones. I sent you an email to chat. You got my number. You wanted to, you can give me a call.
Yes. I think I got your email. Yeah, thank you, Mike.
Thanks, bye-bye now.
All right.
Thanks, everybody. Have a wonderful week.
Yeah.
Thanks
thank
again
you
for
for the
attending. We
contributions.
really
They were excellent.
appreciate it.
Excellent. Yeah.
Thank you from Toronto.
Yeah.
Thank you.
You're welcome.